Only mode.
Good afternoon. I'm Lorna Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Dr. Timothy Kuzel, our expert presenter for the 7th eCourse of our series hosted by the Institute for Clinical Immuno-Oncology, or also known as ICLIO, who will discuss immunotherapy for the treatment of metastatic renal cell carcinoma. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapy, includes other vital resources such as newsletters, papers, scholars program, and a national conference, which for 2016 will be held September 30th in Philadelphia. Please visit www.accc-iclio.org to browse all of our offerings, including our new released white paper. Now for today's eCourse, I'm pleased to introduce Dr. Kuzel, who's Professor of Medicine and Dermatology at the Northwestern University, Feinberg School of Medicine. Additionally, he's the Director of the Clinical Research Office at the Robert H. Lurie Comprehensive Cancer Center at Northwestern University, and is also the Director of the Driskill Immunotherapy Research Program at Northwestern. He's been frequently listed as one of Chicago's best doctors, and he's co-authored or authored over 250 journal articles, editorials, and book chapters, and has edited several textbooks. Dr. Kuzel participates on numerous national, state, hospital, university, medical school, and cancer center committees, including multiple NCCN guideline panels, and is past president of the Illinois Medical Oncology Society, and is active in numerous professional societies. So now, for a couple housekeeping notes about the webinar today, please feel free to submit questions to our presenter by typing your questions in the box on the dashboard. We will also be joined by Dr. Jake Ginto, who will pose questions to Dr. Kuzel at the end of the presentation. Our webinar today will be archived, and it will be available on the ICLIO website. Now I'll send it over to Dr. Kuzel to kick off the webinar.
Good morning or afternoon, depending on your location, I guess, across the country here. Thank you all for joining us. Today we are going to talk about the immunotherapy of renal cell carcinoma. My financial disclosures are shown here. Next slide. I will mention some off-label use of some products during this presentation. So I think it's important to start with a little background regarding kidney cancer. Kidney cancer is a heterogeneous disease. Clearly, we have learned a lot about the different histologic appearances of kidney cancer over the last 20 years or so. But much more recently, we've also recognized that each of these varied histologic presentations are often associated with very unique chromosomal changes and activation or inactivation of certain genes that are in the kidney cells. We've also learned that the cell of origin of a number of these different neoplasms are slightly different along the parts of the kidney, ranging from the glomeruli down through the collecting system, and ultimately, of course, leading into the ureters. Now, we're going to talk predominantly on clear cell today, which is characterized by loss of the von Hippel-Lindau protein function. And we're going to talk about that predominantly because that is the tumor cell which has had really all of the development of the new drugs responsible for it. These other tumors may or may not respond to immunotherapy. A lot of that data is still under development at the moment. Next slide, please. So we're going to begin with a case presentation. This is a 58-year-old Caucasian female who presented in November of 2011 when she was found by her primary care physician to have developed a new onset of anemia. A CT scan was ordered, and it revealed the presence of a 9.5 centimeter right renal mass. The patient was referred to a urologist, and because there was no metastatic disease at that time, the patient underwent a nephrectomy, and this revealed evidence of a high-grade, Furman grade 4 clear cell renal cell carcinoma. A number of immunohistochemical stains were performed to confirm those findings. CA9, for example, was positive. As is the standard of care, no adjuvant therapy was delivered off of a clinical trial, and none was offered on a clinical trial at that time. Next slide. She actually then was referred to medical oncology because in November of 2013, she had begun to develop weight loss and new development of left-sided chest discomfort. Repeat CT imaging was obtained, and you'll see some CT images here in a few minutes, and that revealed the evidence of new pleural involvement by extensive tumor, as well as several distinct pulmonary nodules. She was otherwise a healthy woman, except for the prior anemia, and she had developed an asymptomatic pulmonary embolism, which had required anticoagulation for a period of time after her nephrectomy. Her physical examination was largely unremarkable, except for decreased breath sounds in the left lung base. Her performance status was approximately 80 on the Karnofsky scale. She had a normal LDH and calcium, and certainly at that point, there were questions about what kind of options for therapy would be appropriate. I don't know if we have a way of querying our audience to see if anybody has any suggestions or thoughts, or we can move on. Why don't we go to the next slide and we'll address some of these issues. So the major focus of therapeutic research development over the last decade really revolved around the fact that it was finally elucidated that in clear cell kidney cancer there is inactivation of the von Hippel-Lindau tumor suppressor gene, and that gene functions to create a protein which is really designed to target a number of other proteins for regular scheduled destruction to allow for no over expression of certain proteins. When you have inactivation of the VHL gene, you end up accumulating a number of other cellular products and proteins, and it's been recognized that in clear cell renal cell carcinoma, many of those factors are pro-angiogenic, like VEGF or platelet-derived growth factor. Thus, the target for much of the therapeutic development over the last decade has been agents which interfere with signaling for angiogenesis, and therefore actually the targets are often not necessarily the tumor cell, but actually the endothelial cells, which are shown on the upper right of the cartoon here. And the drugs that have been developed really had two separate distinct pathways. A number of them interfered with VEGF and PDGF signaling. Bevacizumab, of course, is an antibody which binds directly to VEGF and prevents its interaction with the receptor. Sunitinib, sorafenib, and pazopanib are agents which actually interfere with signaling downstream after VEGF binding. The other sort of cluster of drugs that have been developed are mTOR inhibitors. mTOR has also been recognized to be a cellular signal for proliferation. It may also actually have a role to play in angiogenesis as well, but there are actually two distinct mTOR inhibitors which have been developed as well, temsirolimus and everolimus, and those agents are mTOR inhibitors which have also been approved. All of these so-called targeted therapies are generally felt not to be curative. They result in sometimes relatively high rates of disease remission and regression, but on average, those benefits only last between probably 8 and 12 months, depending on the study that you look at. Next slide. So prior to the targeted era, really renal cell carcinoma was a relatively difficult disease to manage for many practicing oncologists, and frankly, outcomes were relatively dismal. You can see on this slide that trials of things like hormones had been tried over a number of years. Systemic chemotherapy, of course, had been tried in large numbers of patients, and you'll see that compared, frankly, to observation and no treatment, survival was really no different. Median survival time 6 to 9 months with disease. Now, there were a number of patients that had been recognized during those years who had some slight benefits with a cytokine, alpha interferon, and actually important studies were done a little bit more recently which pointed out that if you did a cytoreductive nephrectomy, even in the setting of metastatic disease, before you administered systemic immunotherapy with interferon, patients actually did significantly better than if you left their native kidney in place. And that has really been a paradigm that has been followed now for patients receiving immunotherapy. And there may even be some rationale in some studies, although not prospectively done, to suggest that nephrectomies prior to targeted therapy may also enhance outcomes. But certainly this suggested that perhaps immunotherapy did have a role to play. And next slide, please. And really for the bulk of my career, the only active and significantly effective immunotherapy was a drug called interleukin-2. The drug actually was discovered back in 1976. It was initially obviously identified in the laboratory as an agent which stimulated the growth of T lymphocytes. It was ultimately generated with recombinant technology, and it was administered to some of the first cancer patients in 1983. And as a matter of fact, at the recent immunotherapy meetings, Dr. Steve Rosenberg showed a slide of one of the first patients to respond 30 years ago with this drug, doing well, still alive. So it was recognized that there was something unique about this drug, and it was also recognized that there was something unique about certain patients, because it was clear that this drug did have evidence of some durable, long-lasting remissions. Ultimately, phase 2 trials began in 1985, and in kidney cancer, the drug was actually approved on the basis of a phase 2 trial, ultimately in 1992. Next slide, please. So IL-2, as I said, was initially thought to represent a T-cell growth factor. It is produced exclusively by activated T cells and predominantly CD4 positive T helper lymphocytes. And it is correct that it does result in the proliferation and activation of T cells. It interestingly also results in NK, natural killer cell expansion and activation. There is enhanced antibody production because the T cells often secrete other factors when they proliferate and are activated, which cause a more global immune activation. And thus, there's been always some debate about the mechanism of action of IL-2, whether it relates to the IL-2 itself, whether it relates to the T cells, whether it relates to some of the secondary cytokine release, like gamma interferon, for example. Ultimately, however, one of the drawbacks to IL-2 administration, especially high-dose IL-2 administration, is that some of the very same secondary cytokines which may provide benefit also result in toxicity, such as capillary leak syndrome, which leads to hypotension, can lead to leakage of fluid into organs such as the lungs, and has been associated with a small risk of death in almost every study that's been done to date. Trying to block those secondary cytokine effects for toxicity has really not been an effective strategy. And even more recently, it was recognized that IL-2 is a potent generator of regulatory T cells, and therefore, at the same time, it stimulates its own production and the response of a beneficial T cell proliferation. It also downregulates that very same T cell proliferation with the regulatory component. Next slide. So this is a standard schedule for high-dose IL-2. It is given nowadays probably at select centers, typically university centers, and even the number of university centers seems to be dwindling. Recent publications suggested that no more than several hundred patients every year with kidney cancer receive this treatment. It is given for a week in the hospital. You then go home for about 9 days, and then you return to the hospital for a second week of treatment administration. Common doses and schedules are illustrated above the schema there. And normally, there is a rest period then for anywhere from about 4 to 9 weeks. And if a patient is a responder, a repeat treatment cycle can be administered, especially if the patient had acceptable toxicity with treatment. Next slide. And these are some of the early trials. The single-arm high-dose IL-2 phase 2 with 255 patients actually represents the approval data set. It was done at a handful of centers in the late 80s. And you'll notice that the objective response rate in that trial was only 14%. If you actually go back and look at those patients, a few things will jump out at you. First of all, they were not selected for clear cell because we really didn't know the difference in the 1980s between clear cell and non-clear cell renal cell carcinoma. In addition, many of those patients had undergone prior therapies. So it was not a certainly treatment naive group of patients. And yet the response rate was 14%, nothing to really be that excited about. But the complete remission rate was 7%. And that was actually what was relatively exciting, and I'll show you a slide in a second regarding that information. More recently, a number of alternative doses and schedules have been sort of piloted. Sometimes the pilot studies with those alternative doses and schedules seem to be relatively active, and therefore there's been interest in seeing if lower dose schedules, which might be more acceptable for a broader population of patients, would yield similar results. And I think the last row there illustrates very nicely nearly 100 patients treated in 3 different arms of a study with high dose versus low dose IL-2 administered either subcutaneously or intravenously. And you'll notice that the high dose IL-2 is associated with a not just significantly better objective response rate, but actually more importantly a better complete remission rate. And therefore the thought is if you're going to treat patients with IL-2, you really should give high-dose IL-2 because that's the regimen which is associated with complete remissions. You'll notice that the median survival time in this trial was not different between the 3 arms. It is significantly longer than an observation sort of historic data set, but that obviously has any number of different biases that are associated with it. Next slide. So as I alluded to, the reason to treat patients is the complete remission rate, and that is associated with a significant duration of response, the so-called tail of the curve. And this was, again, from the approval population, so it's a little bit less active than some of the contemporary trials. But you'll notice that nearly 70% of patients who achieve a complete remission appear to be cured of their disease. And as a matter of fact, I usually tell my patients that if they are disease-free for more than 3 to 4 years, the likelihood of relapse is very small and almost vanishingly rare. A number of correlative studies attempted to identify the people who did respond, and it wasn't at all clear that patients had to have small, minimal residual disease. As a matter of fact, a number of patients with bulky liver metastases in these trials responded. Many of the partial responders had dramatic regressions, and some of those patients can be then converted to surgical complete remissions. And that's an important strategy because even partial remission patients, there are long-term survivors seen with those patients. So again, it's not routinely administered at many sites across the country, but for a younger, healthier patient who is able to withstand the toxicity of potentially some hypotension, stress on the cardiac system, this is a treatment which is associated with long-term durable remissions and even more importantly, no induction of autoimmunity. Next slide. So the frustration with high-dose IL-2 and the reason some people don't give it is illustrated here from our own experience. Despite the fact that we have some patients with striking, durable, long-lasting remissions, there's just no impact on median overall survival. And for really many years, medical oncology has focused on improving median overall survival as a critical endpoint to determine value in products. And therefore, many practitioners felt that given the toxicity, given the lack of improvement in median overall survival, there really is no reason or was no reason to refer patients if they did not give it themselves, and there was no reason to administer it themselves. Next slide. Now this is the most contemporary study with high-dose IL-2. This was done by Dave Mcdermott, led by Dave Mcdermott. It was a multi-center experience. And the real question in this trial was designed to address issues of predicting responders based on a number of features. Bob Motzer had developed the Sloan Kettering risk group stratification. UCLA with Dr. Figlin had a similar risk group stratification. And by the time this trial was done, much more recently, we did perceive and understand that there were clear cell and non-clear cell renal cell carcinoma types. So again, the interest was to see if patients had non-clear cell responded or if they didn't, and to try to clarify outcomes. And you'll notice here in an untreated group of clear cell population patients, response rates are actually 30%, which is the highest that has been seen in these trials, and certainly compares favorably to some of the novel, newer immunotherapy strategies we're going to talk about in a few minutes. Unfortunately, this slide also illustrates that using the MSKCC risk group, for example, stratification, did not, as many people would have assumed, the favorable and intermediate, less symptomatic, healthier, smaller tumor burden patients might do better. As a matter of fact, it appeared just the opposite. Patients with poor risk disease actually did better. And that's an interesting concept, and we can come back a little bit later to that same concept with some of the newer agents. Next slide. So returning to our patient, she was being seen at a center which can administer high-dose IL-2, but the feeling was, given her chest discomfort and given the impact on her respiratory pulmonary function due to the infiltration of her lung by her disease, she would not tolerate IL-2. So instead, she received a targeted therapy. She received sunitinib for 4 cycles, and then she had relatively rapid progression, obviously only about 6 months of benefit, and she was changed to everolimus from May 2014 to October 14. Her CT scans showed tissue stability, but then she also developed several new bone lesions, and therefore she was then changed to another tyrosine kinase inhibitor, axitinib, at that point in time, and she received it for a few more months until May of 2015, when further progression of her disease was noted. Throughout the time, she remained stable. Her performance status was basically an ECOG 1, and she was definitely interested in other approaches. Next slide. So this slide illustrates a series of her CAT scans. You can see that in October of 2014, that's after Sutent was administered, and you can see the tumor in the left lung basically encasing it, which obviously was resulting in her chest discomfort and respiratory problems. She then, in May of 2015, after she had been switched to everolimus and then to subsequent axitinib, you can see did have some improvement probably in the bulk of the infiltrative chest wall disease, but another new bone lesion was seen in her iliac crest, her pelvis, again suggesting that she was breaking through therapy. Next slide. So at that point, we faced this question, what other therapies would you offer next? She'd already had 2 tyrosine kinase inhibitors. Certainly a third alternative tyrosine kinase inhibitor could be rotated in to see if that would somehow offer benefit. There's really no data that would suggest that that would be the case. Temsirolimus is another intravenously administered mTOR inhibitor, again in the setting of failure on tyrosine kinase inhibition and everolimus. There's really not a lot of data supporting that rotation. There are some novel immunotherapy agents available, like an anti-CTLA-4 antibody, ipilimumab, or an anti-PD-1 antibody, nivolumab, which had begun to be studied in renal cell cancer by that point in time. And certainly given the history of immunotherapy, the fact that she was not an IL-2 candidate, it was an attractive thought that perhaps she would benefit from anti-PD-1 therapy, for example. Next slide. So what is the data for that thought? Next slide, please. So I showed you the proliferative effects of interleukin-2 previously. Since interleukin-2 was developed, we've learned much more about the immune system and its function and mechanisms of control. And on the left side of this cartoon, you'll notice that there is a T cell, which is in orange, and there is either a tumor, but much more commonly a antigen-presenting cell. And basically, the function of antigen-presenting cells is to scavenge small fragments of proteins from non-self organisms, or in this case, tumor cells. And the APC then presents to the T cell via a T cell receptor the small fragment. And if there is a match, the T cell is stimulated. However, if there is just a T cell receptor match, the proliferation is quite limited. It's also been recognized that co-stimulatory molecules are critical. And actually, a very important co-stimulatory molecule, the CD28, binds to either B7-1 or B7-2, and this results in dramatic development of immune-targeted development by T cells. Proliferation and activation is seen. Now, the immune system was designed with checks and balances in mind, evidently, because as the T cell gets turned on and activates and stimulates, it also begins to upregulate some other pathways. For example, CTLA-4 is a antibody, an anti-CTLA-4 antibody has been designed because CTLA-4 begins to be upregulated on T cells, and it outcompetes for B7-1 and B7-2. So by blocking that, you can prevent the shutdown of those T cells. Now, that typically happens in the lymph node environment. In the tumor environment, it's also been recognized that PD-1 is upregulated on many activated T cells. Often gamma interferon results in the increased expression of PD-1, and actually tumor cells have now been shown to express PD-L1, as have a variety of other cells infiltrating tumors, such as myeloid-derived suppressor cells and even dendritic cells. So there are a number of mechanisms by which the T cell proliferation and activation can be then secondarily shut down, leading to suppression, and therefore ways of blocking those suppressive proteins are valuable. So there are a number of antibodies which now bind and prevent the PD-L1, PD-1 interaction from occurring, resulting in reactivation of that T cell response. Next slide. So this was a phase 1 trial done with the PD-1 anti-PD-1 antibody nivolumab. This was a multi-dose study, and patients were eligible who had melanoma, non-small cell lung cancer, kidney cancer, colorectal cancer, or castration-resistant prostate cancer. Any number of prior therapies were often allowed, and it was a fairly standard PD-1 phase 1 design with multiple doses being administered every several weeks. And for patients who benefited, they were allowed to continue treatment. Patients who had deterioration, obviously, or toxicity were taken off study. Next slide. Multiple dose ranges were looked at in this trial. And if you actually look at the left, a difference between 1 and 10, a log difference in dose, resulted in relatively modest differences in response rates, but again, impressive response rates considering how heavily pretreated some of these patients are. This is just the renal cell carcinoma population. The overall objective response rate across doses was nearly 30% in a small number of patients. And again, there was the appearance of durability of some of these responses. Median duration of responses were over a year, with many patients having long-lasting, ongoing remissions. And a significant population had further stabilized disease in addition to the responses. Next slide. This is a spider plot which illustrates changes in tumors over time. This was presented several years ago now by Steve Hody. One of the phenomenon with the checkpoint inhibitors, as these agents are sort of known broadly, is that there are occasional patients who actually will have increase in tumor growth reflected by a rise in the line above the 0 horizontal axis and then subsequent decline. Now that's been seen a little more commonly with the anti-CTLA-4 antibody ipilimumab. You'll notice that with nivolumab, many of the patients had fairly brisk decreases in their tumor burden really at their first assessments. And therefore, the concern about missing perhaps a delayed responder is a little bit less, I think, with these agents than it is with perhaps ipilimumab. But you do need to keep that concept in the back of your mind. Next slide. This led to again, a dose-ranging phase 2 study. This was a randomized phase 2 study that Bob Motzer presented and published about a year ago now. This was a 1-to-1 randomization. The treatment arms were blinded to the patients and the physicians, and you could see that it was a relatively low dose of nivolumab versus 2 mg per kilogram every 3 weeks versus 10 mg per kilo every 3 weeks. Next slide. This shows some of the patient demographics. The MSKCC risk factors were fairly evenly distributed. Many of the patients were relatively good or intermediate risk. About a quarter of patients were poor risk in this. Many patients had multiple sites of metastatic disease, and you'll notice that the number of prior anti-angiogenic regimens was often 2 to 3 in many of these patients. Next slide. Other agents that were often used in these patients included nearly 20 to 25% that had received prior interleukin-2, and about a third of the patients in all the arms had received a prior mTOR inhibitor, everolimus. Next slide. These are the waterfall plots from that trial that has been presented and published now. You'll notice that across the doses, the response rate overall was relatively constant, around 20 to 25%. And you'll again notice that there were complete responses seen in at least 2 of the different arms, the low dose and the intermediate dose. The rate of PD was a little bit less in the 2 mg per kilogram than it was in the 0.3 mg per kilogram dose arm. Next slide. Toxicity, I think, is consistent with what we've come to learn with checkpoint inhibitors and anti-PD-1 antibodies in particular. There is certainly some fatigue that can be seen and some nausea, but these are relatively mild, and the rates of grade 3-4 toxicity are actually relatively modest with these agents, so that patients tolerate them quite well. Next slide. There are patients who develop autoimmune toxicities with these agents, and I think that's the thing that you need to monitor most closely. But those rates are probably about 5 to 10%, including things like colitis, some of the endocrinopathies, eye toxicity or skin toxicity. So a little bit easier to tolerate probably than ipilimumab is for those of you who also treat melanoma patients. Now this is the overall survival Kaplan-Meier curve, and you'll notice that for the 2 higher dose arms, the median overall survival was nearly 25 months. For the lower dose arm, it was about 18 months in this randomized phase 2 experience. And next slide. This slide illustrates sort of how that stacks up relative to other agents and other trials which had studied patients in the relapsed disease setting. And you'll notice the nivolumab data on the far right, 25 and 24 months for the 2 higher dose arms. And that really compares quite dramatically favorable to other trials. Obviously, this is not a randomized comparison, but really for other second-line agents, you'll notice that median overall survival was really just about 15 months at best. So this appeared to at least be a very substantial improvement in the sort of relapsed disease setting. Next slide. Therefore, this trial was conducted and was reported just this past year. This was a randomized phase 3 trial of the nivolumab versus everolimus. So everolimus is approved for second-line disease, at least in the relapsed clear cell population. And this trial was designed as a head-to-head comparison. Patients had to have undergone prior anti-angiogenic therapy, but less than or equal to 3 prior therapies total, and they had to have progression relatively recently from the last dose of their prior treatment. Primary endpoint for this trial was overall survival. Secondary endpoints included progression-free survival, objective response rate, as well as durability of response. Next slide. Here is the Kaplan-Meier curve, which was published just in the New England Journal of Medicine in the last few months. And you'll notice that the curve favors the anti-PD-1 antibody, hazard ratio of 0.73, highly statistically significant, and the median overall survival for the nivolumab arm was exactly what would have been predicted based on the randomized phase 2 experience at 25 months. Unfortunately, the follow-up is relatively short for this trial, so we don't have yet evidence of what that tail on the nivolumab curve is going to look like, but presumably there will be a significant percentage of long-lasting durable responders. Next slide. Now, this is a subset analysis that attempted to look at, for example, some of the different prognostic factors and stratification factors for the clinical trial. And you'll notice that if you look at the MSKCC prognostic score, much like the interleukin-2 experience, where the poor risk patients surprisingly had the most benefit from interleukin-2, here again you see that compared to patients with favorable and intermediate risk, where there's clearly a better outcome with nivolumab, the most dramatically better outcome is actually in the poor risk patients. Other than that, really all of the treatment demographic factors really, with the exception perhaps of elderly, although very small numbers of patients, favored the administration of the anti-PD-1 antibody. And again, similar to other immunotherapy experiences in the last few years, progression-free survival differences are not seen with this agent. Next slide. So this was our patient. We were able to access an anti-PD-1 approach for this patient. And you'll notice that in May of 2015, despite having failed 3 different therapies and having fairly significant disease in the pleural space adjacent to her arch of her aorta there on this image at the top, you'll notice that after 5 months of therapy, she's had significant regression of that disease and basically has 0 symptoms as an ECOG 0 at this point. Tolerating therapy, has not developed any autoimmune toxicity to date, and is doing quite well. Next slide. There's been interest in defining biomarkers in a number of these trials to see if we could better select patient outcomes. This is preliminary work that really began this discussion. It was looking at the expression of the ligand for PD-1, PD-L1, and they basically did immunohistochemical staining on pre-treatment tumor biopsies. This is from a number of different tumor types, which are shown below, only 5 of which were renal cell carcinoma. And in this relatively small study, you'll notice that patients who had PD-L1 expression had actually a very robust response rate. 16 out of 25 patients responded who had PD-L1 expression. On the other hand, if you were PD-L1, 9 out of 25, so about over 35 to 40% had response. If you were PD-L1 negative on that pretreatment biopsy, in this very limited small sample, no patients responded. Now, this has been clearly studied much more aggressively and in much larger numbers of patients now that many of these studies have led to phase 3 studies across disease types. And I think it's clear that we can say that your odds of responding if you are PD-L1 positive are probably better than if you are PD-L1 negative. However, your response rate is not as close to 0 as it was shown here. In addition, PD-L1 expression is actually seen usually in the minority of patients in the treatment trials that have been done to date, and many of the responders in those trials actually were PD-L1 negative. So this is not an absolute predictor, and as a matter of fact, Dr. Motzer just literally in the last week at the GU ASCO meeting presented some updated correlatives from that nivolumab everolimus trial, and in that trial, PD-L1 staining did not appear to predict at all across the two arms for benefit. Next slide. Now, there has been interest in combination checkpoint inhibitor therapy, really driven by the excitement in the melanoma arena, where response rates are quite high with the combination of nivolumab and ipilimumab. This is some preliminary data from a phase 1 trial that was piloting different doses and schedules of combined checkpoint inhibitor therapy in patients with renal cell carcinoma. Next slide. And similar to what has been seen in melanoma, it appears the response rate is higher when you combine the two checkpoint inhibitors. The objective response rate in this relatively small phase 1 experience is around 40% now for patients in the combination arms. And the complete response rate is actually up to about 10%. It's probably lower in the Nivo-1 Ipi-3 because there was more toxicity seen in that arm, and therefore there may be some advantages to choosing a slightly more tolerable combination dose level. Next slide. As mentioned, some of these responses are quite long in with the combined approaches, and this is a slide that illustrates the durability of responses. The swimmer plot bars with the horizontal black arrows indicate ongoing responses, and the red bars indicate patients who've actually stopped treatment. The reason to stop treatment was usually toxicity, and we know that about 50 to 60% of patients will develop autoimmune toxicity with combined checkpoint blockade, which often results in discontinuation of therapy. And yet, despite presumably receiving steroids and stopping the drug administration, and you can see a large number of the patients with the red bars are still having ongoing responses. Unfortunately, we don't know how long we need to treat patients who don't experience toxicity and experience responses. In the earlier trials with single-agent therapy, the treatment duration was often indefinite, so that it's difficult to know how long we should treat patients. Next slide. So this was the toxicity that was seen, and you'll notice that we've included here a number of the treatment-related select autoimmune adverse events, and here you do see grade 3-4 toxicity at fairly significant rates. For example, with the Nivo 1 milligram and the Ipi 3 milligram schedule, nearly a quarter of patients had some sort of GI disorder, and hepatic toxicity was also quite common. The Nivo 3 Ipi 1 appears to have a little bit less in the way of grade 3-4 toxicity, but certainly still has fairly significant rates of milder GI problems, hepatic disorders, and the endocrinopathies. So these are combinations which are not for the faint of heart, and probably should be administered by someone who is comfortable and has used these on a more regular basis rather than occasionally using these combinations. Next slide. So the combination has actually already been studied in renal cell carcinoma. There's a phase 3 trial of the combination versus sunitinib as frontline therapy. There's no data from that trial yet, but it has completed accrual very briskly. We're all waiting to see what shakes out in the frontline setting. But I think a number of conclusions for the immunotherapy approaches to this disease can be drawn from the data. I think it's perfectly appropriate to still offer high-dose interleukin-2 in this day and age. It should be restricted to patients with clear cell kidney cancer, however, and the response rates are quite favorable, nearly 30%, and a significant percentage, probably 5 to 10% of patients will have long-lasting durable remissions. Although short-term toxicity can be significant, there does not appear to be significant autoimmune toxicity, with the exception perhaps of hypothyroidism. In the relapsed disease setting, single-agent anti-PD-1 therapy is now approved, and again, shows importantly and interestingly improved median overall survival time compared to the historic controls, as well as in the randomized trials. Combination of CTLA-4 inhibition and anti-PD-1 inhibition has even more impressive, some of the best response rates, certainly rivaling those of the targeted therapies, but also have durability. But toxicity, unfortunately, appears consistent in kidney cancer with the experience in some other disease sites to date. And as I mentioned, the combination trial with sunitinib is completed accrual already. The next slide. I think we'll open it to questions. Thank you all for your participation and attention.
Thank you, Dr. Kuzel, for that very educational presentation. And we do have time for a couple questions. So the first question has to do with the sequence of therapy in renal cell carcinoma. So in addition to nivolumab and ipilimumab combination being studied to treat patients with renal cell carcinoma, there are a number of other therapies in development, other checkpoint inhibitor therapies in development, such as atezolizumab in combination with bevacizumab. Now, as these new checkpoint inhibitors enter the market, where do you see them being used? Like, do you envision more than one checkpoint inhibitor being used within the treatment sequence other than in combination? Or do you think they are too close in mechanism of action, like, for example, an anti-PD-L1 versus an anti-PD-1?
Right. So it's not at all clear, given the similarity in mechanism, that rotating from one PD-1 or to a different PD-1, for example, in melanoma, or in rotating to an anti-PD-L1 is probably going to make a lot of difference. I think it's an interesting question. And I think it might make more sense if, for example, a patient received atezolizumab as an anti-PD-L1 plus bevacizumab as frontline therapy. If that trial gets up running and shows benefits, maybe it would make more sense then to segue to a combination approach, but that's going to really require a little bit more data before you can make blanket statements. I think that the combinations with other targeted therapies have been a little bit problematic. Toxicity has been difficult, combining some of the anti-VEGF small molecule inhibitors with some of the anti-PD-1. So I think that that combination needs to probably be studied in larger patient numbers to make sure it's an acceptable, tolerable therapy.
Okay, thank you. And we have time for one more question, and this question actually relates to the use of biomarkers, and you referred to biomarkers in your previous slide. So you showed the study showing clinical activity in those patients that express PD-L1, and then you mentioned that PD-L1 may not be an absolute predictor, and I think it was that phase 3 trial you spoke about. Now, how do you see biomarkers evolving, in RCC, especially with the approval of pembrolizumab in non-small cell lung cancer, which, in order for patients to use pembrolizumab for that indication, they need to overexpress PD-L1.
Right, and that's a function of the design of the studies. So many of these studies are done nowadays with companion diagnostics, and I think they're done with companion diagnostics partly to develop the companion diagnostic, but also to sort of hedge the bet of the pharmaceutical company. If the overall trial is not as impressively positive as they would like, if they've powered it appropriately for the biomarker expression, they are able to then pursue perhaps approval based on the biomarker expression. And I think that's what happened in lung cancer. I think the all-comer population was diluted somewhat so that the benefits weren't as obvious. But when you looked at the subgroup analysis, which was appropriately powered for analysis, they showed enough benefit that the FDA gave it that caveat. It's important to remember each of the different tumors that have been studied, the target cell for which PD-L1 expression is investigated is often different. It's been shown to be immune infiltrating cells in some tumor cells, or in some tumor models. It's been tumor cells in some tumor models. So these assays are not easy to do, and I'm not sure that your average pathologist at your average hospital doing immunohistochemistry is going to be able to really determine that. So I think these really will require probably standardized assays at standardized laboratories, but the biomarker in some cases may be important, but clearly it's not required in the melanoma or the renal cell field to date.
Thank you, Dr. Kuzel. I think that's all the time we have right now for questions. I'm going to hand this back over to Lorna.
Great. Thank you so much, Dr. Kuzel and Dr. Ginto, for the engaging presentation, and thank you to our audience for participating. The webinar and slides will again be available on our website, which is accc-iclio.org. And all registrants will also receive an email with the link. Be sure to register for our upcoming webinars, Navigating Patient Assistance Programs on January 21st with Charles Lynch, and Coordination of Care for Immunotherapy Patients with Catherine Schott on January 27th. Thank you so much and have a great weekend.